Okay, everybody, we have a pretty packed agenda for today, so we're going to go ahead and get started. And we are doing Adolescent, Assent, and adults with diminished decision-making capacity. But first, we have a very special presentation from Julia Spasitseva. And yes, that is the correct pronunciation of her name. So let me invite Julia down really quickly.
Thanks, Joshua. My name is Julia Spasitseva. I am currently in the Office of Clinical Research Services in the Sponsored Programs Administration. And one of the duties that fall under my jurisdiction is I am the business owner, or we're the business owners of the Velos system. Now, we design various processes in Velos, and for those of you who work in Velos will know what I'm talking about, but we do this together with our partners on campus. And today's slide is really to announce that we have a new process in place for those of you who conduct your studies at university hospitals, specifically studies that require pathology or laboratory services, whether you're conducting those at Zale or Clements University Hospital. So for those of you who are familiar with this process, you may know that up until recently you had to submit a paper form or an email directly to Sunil Verma. So I don't see Sunil in the audience, but for those of you who worked with Sunil, you know his name very well. And starting now, we have a process in place in Velos where you would submit the requests to Sunil via Velos, where we can track those. And also our site approver then, Jean Hoysenert, and I don't know if Jean is in the audience, will be using that information in Velos towards overall study approval and site approval. So just very briefly, for those of you who picked up a handout, I'm not going to go into too many details, but the process is very straightforward. We've outlined step-by-step instructions on how to submit it. I will stay until the end of the presentation. If anyone has questions about the process, again, if you've not been doing this, if your study never required that you collect samples or specimens at university hospitals, this will not apply to you, especially if you're doing your studies primarily at Children's and or Parkland hospitals. I will be also following up with a listserv announcement this week with additional instructions as well as the links to some of these handouts. So feel free to reach out to us at that point as well. Thank you very much, and thanks so much for the 5 minutes you allowed me to present this. Okay.
She actually only used like 2.5 minutes, so I get more time back to talk, and I know everybody just loves listening to me talk, my wife included. Okay, so we'll do the quick updates like we normally do. So we have metrics and EIRB and website updates. So metrics, this is what we've experienced in the last 6 months. We did see a little bit of a dip for pretty much all submission types around the spring break time. I know that was a long time ago in everybody's minds, but we're just starting to kind of see some of that dip a little bit now, especially with the full board team because of their meeting schedule, but we still continue to be very busy. For the full board team, we're up at 61 median days from submission to final approval. And one thing I will mention is that Rhonda has asked the different teams, the full board, the expedited, Reliance, and our monitoring specialists to start presenting their metrics at our meetings. They're going to be doing that, I believe, every 3 months. And what we're really looking to do is, we know that their full board team right now is at 61 days, and we're hoping that they will take that and own it and then present ideas of how they can get that down to the goal of 35 median days. So it's something that we're working on to empower the staff of what they're doing on a day-to-day basis, that they can reduce the metrics for their team. For expedited, they're doing really fantastic. They're at 25 median days. For exempt, we're below the goal, so we're at 19 median days. For Reliance, we're at 17, and just like I mentioned in this is April, so when I mentioned in March that Ranya's team really is affected by people that don't necessarily work at UT Southwestern or within the HRPP office, we really sometimes are beholden to what those external IRBs or other sites are providing to you and or to her. So she does the best she possibly can. If you want to see that number dip down quite a bit lower, as you have new Reliance studies, email Rania and set up a intent to rely meeting as soon as you know about it, because we will let you know that a lot of times if we reach out to the IRB that is going to be reviewing this study, we get answers sometimes back and they're the correct answers quicker than you may get them from the CRO or from the coordinator that's working at that other site. We speak IRB language and then everything works out great, but if you try to speak IRB language to the coordinator, they don't necessarily understand that. And that's fine. That's why Rania has a job. So then quick EIRB and website updates. So there was a lot of information that we sent out via the listserv about a week and a half to 2 weeks ago. So I'd ask you to hold all your questions to the end. But we do have the handout, the listserv information that we sent out. Those were available at the tables. And just quick note, expect more changes in the future. We're working on a lot of really big changes to the website, like I announced last month, and we're working on changes to EIRB. We're really looking to improve our product so we can serve you better, and it's going to be a never-ending process. It's just going to hopefully be continual better product for all of you. So, and then while I'm transitioning, for those of you who were able to attend last month, you all were asked to enroll into or go to that website, menti.com, and enter the code, and we were doing something that was, audience participation. We found out after we used it that we should have gotten approval from an institutional committee here at UT Southwestern, because it does contain data from all of you and from me that's being stored by the company offsite. I think you would all agree it was very non-identifiable data, but it does still require that they review and approve it. So we're pending approval from them next Tuesday. So if you come back in May, we'll be using that very heavily, assuming that that committee approves it for us. I do have questions embedded in today's presentation. I don't know why that is still showing up, but anyway, click the wrong one. I still do have questions embedded in today's presentation, so I'm going to ask that everybody be brave and raise your hands for the answer that you actually think is correct. The reason we love that piece of software is that it doesn't allow you to look around and see whose hand is coming up and be like, oh, you know what, I know Jan deals with adults with diminished decision-making capacity all the time, so I'm going to look to her to see which answer is right. Or William is the children's research educator, so he's going to know everything that is right about Assent. Don't look at him, just raise your hand when you think it's the right answer. So without any further ado, again, this is the fourth in a series at Research Matters, and in May we're going to do a full recap, and we're really going to try and reinforce the knowledge that hopefully all of you have gained today. What I would love to impart to everybody today is that even if you don't work with children or with adults who we know going into the consent process have diminished decision-making capacity, that doesn't mean that you won't ever work with children in the future. And it doesn't mean that if you are working with mostly adults, that you won't see somebody who potentially does have diminished decision-making capacity. For example, if you're working on a study where you're enrolling healthy adults, and there's not necessarily an exclusion criteria for traumatic brain injuries, somebody could go to the ER, based on a TBI, they're still enrolled on the study. That person now has diminished decision-making capacity, or they might actually be incapacitated. If you want to continue their participation on the study, they now fit into that study group. So it's really important that you understand when these vulnerable populations may be included in your study. So applicable definitions, and you'll see there's some more for this particular presentation. Children are those who have not reached the age to give legal consent for treatments or procedures. Assent is an affirmative agreement to participate in research. Permission is the agreement of parents or guardians for the participation of their child or ward. Parent is a child's biological or adoptive parent, and a legally authorized representative is somebody who's authorized under applicable state or local law to consent on behalf of a child or person. And so I added this one as well. We actually clarified this within the HRPP office because this is, I think, going to be confusing in the future. Impaired and incapacitated subjects are those who don't have the capability to consent for themselves. They're impaired or they're incapacitated. They can give assent potentially, but they do not have the capacity to understand either the information that you're giving them or voluntarily actually indicate that they understand and that they want to participate. The ability to give consent really requires those two steps. It requires both understanding and synthesizing that knowledge into a decision that they want to participate or don't want to participate. And that's a complex mental process. Subjects who have diminished autonomous decision-making capacity, they can give consent because it's diminished. It is not impaired or incapacitated. It might be lower than it would be on a normal day, but they still have that capacity. If you ask me to make a life-changing decision when I wake up in the morning, I'm going to have a different level of capacity than I do right now, and that's normal. We go through stages in the day where we have the capacity to make really important decisions and points maybe at the end of the day where we're mentally exhausted and we really don't have as much capacity as we would otherwise. So it's really important that you understand potentially what population your subjects may fall into. So today we're going to have 4 performances. We're going to have 2 on adolescent assent, 1 where there may be opportunities for improvement and 1 where there may not be any opportunities for improvement, but I'm not going to tell you that there are absolutely not any opportunities for improvement. And then we're going to have 2 where it's going to be adults with diminished decision-making capacity, the same way as we did with the children. So, for a minor who does not assent or dissents, should not be enrolled into a study without benefit. How many people think that is a true statement? That if they do not assent or they actually dissent, that they should not be enrolled into the study? So I'm seeing some hands. Keep being brave. How many people think that is false? How many people are confused by the way I phrase this question? Yeah. I wrote this question a couple weeks ago when I wasn't aware that I couldn't use Menti, and I had to keep it very, very short, so I really had to try and keep the wording as little as possible. So the correct answer is true. If the child does not give assent or actually dissents, they should not be enrolled into a research study. The without benefit part is there, and it does apply in some very it applies in a very few cases, but it was really there just kind of as to trip you up with extra information. So we'll go on to skit 1. So I did give some information about the study today. It's a double-blind, placebo-controlled study on Plomox, an anti-acne medication. For anybody who remembers the February presentations, this was the same drug that had effects on the cardiac system. It prevented Eric from getting gas gangrene. It's a really amazing drug. You should check it out. And the patients have a 50-50 chance of receiving the study drug versus placebo. So without further ado, the first skit.
Hi, I'm Amy. I'm the study coordinator.
Hi, Amy. I'm Allison Johnson.
Hi.
My daughter, Jan.
Hi, Jan. I'm here to talk to you today about the clinical research study that you talked to the doctor about.
Yeah.
It's a double-blind, placebo-controlled study for Plomax for acne.
Right.
Do you remember talking about that?
Yes, yeah.
Great. So are you still interested in that study?
Very much, yes.
So you'll come to the hospital 2 times. You'll get 46 blood draws, and you'll get an infusion of the drug, or you might get a placebo. But
Right.
the drug is free, so you don't have to pay for the drug.
Right. That's the big thing to me. And I read through this, and the doctor really answered all my questions really well. So
Great.
I'm ready to go.
Jan, are you interested in being in the study?
Jan, you need to listen.
Are you interested in being in the study? You get an Amazon gift card for $100.
I get $100?
Yeah.
Well, I know that there was money per visit that we had talked about. Is
Right,
that?
and that's the gift card's on top of that.
So
Okay.
I get it, you don't get it. I can do whatever I want.
Right.
So what do I have to do?
You have to be in the hospital a couple times, and you'll get some blood draws.
For acne?
Yes.
Yeah, no.
No, we really need to do this, honey.
I'm not coming to the hospital.
I
I'm
need
this
you to
cheerleading
do
practice.
this.
I'm not
Yes.
doing this.
I need
Mom,
you
if
to do
you
this,
sign
babe.
the consent right
Yeah.
But,
Okay.
but I don't want to do this.
Yeah, well, we're gonna do this.
Fine.
So sign right here, this is the assent.
Really?
All right, I'll go get a copy of this for you. If y'all have any questions in the meantime, just let me know.
Great, thank you
Thank
so
you.
much.
Okay, so what were the opportunities for improvement? Okay, I'm getting. Oh, I didn't specify that. She's 13. Yeah. So, okay, so that's a good clarification. Thank you for picking up on that. She's 13. So what were the opportunities for improvement? Yes. Yes, she did not. So I'm going to repeat all the answers so that the microphone gets it and so you can watch this later in the future. She didn't really get assent. Theoretically, during the whole discussion, potentially even with the doctor, there really wasn't any assent process that happened. The patient had the headphones on the entire time. So that was one. Yes, the patient dissented, said, no, I don't want to participate in this. So that's the second one. Yeah.
Is the person who's accompanying her a legal guardian or?
Yeah, so she did explain that she's her mother, but the coordinator really didn't confirm or do anything beyond just walking in and getting an introduction. That wasn't one of the opportunities for improvement I formally noted, and we actually worked on that right before this, so great job on picking up on that. You should always confirm the relationship, because it's really easy for you to walk in, grandma and daughter, or grandma and granddaughter. But that doesn't always mean that grandma has the ability to actually give consent for the child. There is some Texas law that allows a grandmother to potentially consent on behalf of a granddaughter, but if you don't necessarily even understand that relationship, then you really need to make sure that when you walk into the room, you get confirmation of what the relationship is, and then determine whether or not the person actually has the ability to give consent for that person. So the third option, we made it pretty, yeah. Yes. Yeah, so we tried to figure out what was really coercive for a child, because I don't know about anybody in the audience, but for me, when I was 13, it would have been Toys R Us. You give me a Toys R Us gift card, and I'll do whatever you want. That doesn't really apply anymore, given the current business climate. But we were thinking, iTunes or Amazon, something that's really specific to what a 13-year-old may want to use. And you notice that was on top of the money that the mother got. And sometimes that's appropriate. Sometimes the IRB will actually approve studies where there's specific compensation for the child. But, and in this case, it might not have been that coercive if it had been presented in a different light. That study required 46 blood draws, a lot of visits to the hospital. So it may not have been that coercive to actually compensate the child for his or her time. But the way it was presented as, we're going to give additional money to you so that you can participate, and then mom really was the coercive force of, no, you're going to do this, and you don't have a choice. So those were the three that we specifically built into the skit. So we'll go ahead and go on to skit number 2, and it's the same study. And I forgot to mention that for this particular study, patients have failed most other standard of care treatments and creams for acne. So without further ado.
Hi there, my name is Amy.
Hi, Amy, I'm Allison Johnson.
Hi.
This is my daughter, Jan.
Hi, Jan. So your mom?
Yes, I'm her mother.
Great. Hi, Jan. How are you?
Good.
So, Jan, can I get you to take off your headphones, please? Yes, please. So, I'm here to talk to you today. Do you mind putting down your cell phone for me? So I can have your undivided attention. So, I'm going to talk to y'all today about a research study for acne. It's a double-blind, placebo-controlled study on Plomax for acne. So you have to be hospitalized a couple times, and you may or may not receive the drug, and you get 46 blood draws while you're in the hospital. So this is for acne, that's correct. So this is for patients that have already failed some other treatments for your acne. So the doctor really believes that this will work for you. So placebo-controlled, that means that you may or may not receive the active medication.
What's a placebo?
So it's kind of like a sugar pill. So you may get the medication that helps your acne, and you may not get it.
This time it's okay.
Moms are good about that.
Never been one that have not been heard, but okay.
So you'll get a $100 gift card to Amazon, and that's on top of the
Oh, okay, good.
compensation that we had discussed before.
Good.
But wait. I may get the drug or I may not.
That is correct.
So
You
why am I
may-
going through this if I'm not going to get the drug? I don't get it.
So the doctor believes that this is a good research opportunity for you. It helps people in the future learn that this is actually better than other medications.
But I may go through this, my acne won't get any better.
That is correct.
Jan, I really need you to do this because it's free medicine, and Dad and me could really use that help with you
I'm
right now.
not doing this.
Jan.
It may not even work. You want me
Jan.
to come get stuck?
I need you to do this.
I'm not doing
You're a
this.
big girl. It's
Yeah,
not
and I'm
going to
not
hurt
doing
you to get a
this.
blood draw.
86 times? Are you out of your mind, Mom?
I think it's 46 times.
Still. I'm not doing this.
Jan, I need you to do this.
I appreciate y'all's time, but she said no, and she's adamant that she isn't interested in doing it, and we have to have her agreement. So I appreciate y'all's time, and I hope to see y'all again. It was nice to meet y'all.
Yeah,
Thank
we're
you.
out of here.
You wait till we get home.
Okay, so there's probably opportunities for improvement in that particular skit, but we really tried to make it so that it was a skit that didn't have a whole lot of errors in it. The coordinator did a really good job of engaging both the patient and the mother in the discussion so that the patient would understand exactly what it is that she was going to assent to. The coordinator really protected the rights of the patient to say no. And for anybody who works in a children's environment and has to deal with this, you will potentially be that, that firewall between the parent really saying you're going to do this and the patient's rights being respected when it comes to research. And it may require some education on your part to say that you actually need both people, the parent and the patient, to give consent and assent. So it's really important that you understand why that's required. It's required that we engage children and get assent from them per the federal regulations, and at UT Southwestern and our affiliates, we've decided that age range is 10 to 17. So per our policy and procedure manual, the HRPP policy and procedure manual, if you're talking about patients who are 6 to 9, it may also be appropriate to get verbal assent, but not necessarily written assent. So we'll move on to adults who have diminished decision-making capacity. So for a subject who's enrolled on a study, they didn't have decision-making capacity before, they regain it. Now that they've regained it, reconsent is required. So how many people think that is true? Be brave. It's a lot of brave people, thank you. How many people think that is false? Okay, so for brevity's purposes, nobody raised their hand. And the answer is true, yes. If you enroll somebody and an LAR consented on behalf of that subject, that patient, participant, whatever you want to call them, and they regain the ability to give consent, you should reconsent them. And when I say should, I'm saying it in the way that the federal government says should, you must reconsent them. So if they regain that capacity, you have to get their consent. Now, depending on the type of study you're doing and how you've described this to the IRB, you may or may not be able to keep the data that you've already collected. If you're talking about a study where it was an ethics study in emergency situations, exception from informed consent, you can keep that because the federal regulations have specifically come out. The FDA has said that data can be kept. If it's in another type of study, then you really should describe that in the IRB application. You should also describe it in the consent form so that the LAR understands that they're consenting that the data can be collected and it may not ever be able to be destroyed. So we have 2 skits. Again, it's another drug, Plomox, dealt with acne, and now it's going to cure Alzheimer's. 50-50 chance to receive the study drug versus placebo. And the patients in this particular study must be capable of completing cognitive testing. Take it away.
Hi there, how are you today? I'm Jan, I'm from the Alzheimer's group. I've come to talk to you about a research trial. You're her partner?
No, not partner. I was sent by the nursing home to transport her to her appointment.
But you're going to come for every visit, right?
Yes, I plan.
Okay, so I'll talk to you. We're going, the Alzheimer's trial it's a double-blind study. It means we don't know if she's going to get the medicine, the doctors won't, and she won't. But we're going to see you. You're going to come every month. We're going to do either drug infusion that takes about an hour, or we'll do an MRI and then do some questionings, and it requires both of you to come. It lasts for about 5 years, and that's about the gist of it. So we'll see you every month. And does that sound okay to you?
It sounds okay to me. How are you feeling about it?
Yeah, I have some questions.
Well, we'll answer your questions later. So since you're going to be here and you're her partner, we'll have you sign the consent for her, and I'll give you copies of it, and you know, we'll just get started in about a month. We'll do some testing. Is that okay?
Okay.
Okay, so just sign here. Super, thanks. I'll go get you a copy.
Okay. Good job, everybody. So, what were the opportunities for improvement? It was perfect, right? No opportunities for improvement? Who's brave enough to answer? Yeah, go ahead.
Well, she obviously needed to find out the patient's name and communicate with her and answer questions.
So I'm going to take it in a slightly different direction. She really failed to understand the patient and the person in the room. She didn't explore that relationship whatsoever. And that's going to be pretty common when you're talking about adults who have diminished decision-making capacity or impaired or incapacitated decision-making capacity. So what was another one of the errors? Yes. Right, and she didn't know, so he signed the consent for her, and he didn't know why he could sign consent on behalf of the subject? Yes.
He would not be an approved LAR or stand-in for a LAR.
It's possible that he may not be approved as an LAR because what he said is that he's just being sent by the nursing home. So we won't go too far into that relationship, but we don't know that he's the LAR whatsoever. So just for time's sake, I'm just going to skip to when the patient was engaged in the conversation. The coordinator really just ignored the patient. And not necessarily just in terms of answering the questions, but the patient seemed maybe a little bit with it. The patient said, I actually have some questions based on what you just told me. So based on that, I'd like to have some questions answered. So the coordinator really ignored that and failed to get assent from the patient, because assent does not just apply to children. Assent also applies to adults who have impaired or incapacitated decision-making capacity or diminished decision-making capacity, and they don't feel that they can make a decision for themselves.
I also did not assess her capacity whatsoever.
Yes. So our policy and procedure manual requires that every time you go into a room with an adult, a child, really any person who's going to consent to a research study, you should have some sort of assessment on their cognitive status. We tend to do that in normal informed consent by asking them, did they understand the study? Perhaps using the teach-back method. And that's really where we get into, was the consent voluntary? Did they have enough time to actually consider their participation, those sorts of things. We don't think of it always as cognitive assessment, but we're really seeing, did they understand what we talked about? Did they make a decision to actually participate? Or are we talking about a mother whose child just came into the ER through a very traumatic experience, and the mother has no ability to actually understand what the coordinator's saying? because the mother is just way too focused on her child. In that particular instance, yes, the mother can make decisions, but she doesn't necessarily have the ability to understand what Jan was going to say about a potential research study. So those were the 3 errors. I'm sure there were maybe a couple more, just a few. But we'll move on to skit number 4, same study, same amazing drug Plomox.
Hi, I'm Jan Watts. I'm with the Alzheimer's unit here at the university. How are you?
I'm good. How are you today?
And what's your name?
My name is Amy.
Okay, and are you the patient?
I am.
Okay, hi, Amy. And you are?
Jadai.
Hi, Jada. What's your relationship to Amy?
I was appointed by the nursing home to transport her to her appointments, and I'm also her LAR.
Okay, did you provide paperwork to?
I had provided it to the nurse previously.
Okay, cool. So that's all clear, and you realize he makes decisions for you with your medical care.
That's correct.
Okay, so I'm going to explain our research trial to you. We're going to give you a drug. It's an infusion. It goes with an IV. You'll come in every month. She'll either have the drug or she'll have an MRI and some testing. And you'll both have testing, so we'll both be asking you questions about it. This goes on for 5 years. It's a long time, but your assistance is required. You'll still be there for the 5 years?
I'm
That's
planning
your
on it.
commitment?
I'm planning on it.
Okay, cool. So you get along. So Amy, did you sort of understand what I said
I do. I
about the
have a
trial?
couple questions.
Sure, what are those questions?
You said that I'll get MRIs, a lot of MRIs every other month.
Yes.
Are those harmful?
No, those are magnetic. It's not. There's
Okay.
no radiology to it at all. So I gave you some information. How long is this study gonna run for?
5 years,
Okay, and how often are we gonna see you?
every month. I'll
Okay.
either get an infusion or an MRI.
Okay, and in that infusion, are you sure you're gonna be getting drug or not?
I think you said I could either get the drug or a fake.
Okay, and you're okay with that?
Yes, I think it's okay.
And you're okay with that?
And she's having a really good day.
Okay, so she seems fine and she understands my trial. We'll have her sign the consent, and as long as you assent, give your permission to, then we'll enroll you in the trial. Is that okay?
All right,
Feeling
sounds
good
good.
about it?
Yeah,
Wonderful.
I'm okay with it.
Good, I'll have you sign, and then we'll give you copies of your consent.
Okay.
Thank you so much.
Can we get a round of applause for our actors? So I'm sure, just like with the correct adolescent Assent skit, I'm sure there's still opportunities for improvement, but it was much better than the previous skit, I'm sure we could all agree. Jan walked in, introduced herself, understood the relationship between the patient and the LAR, and actually assessed whether or not the LAR could give consent on behalf of the person. Now, we did discuss, as we were planning this, should we have Jan walk out of the room, actually go to the medical record, like Sam did last month, and go beep, boop, and confirm in the medical record we have proof. But it's something that Jan actually said that they tend to do after the consent discussion has happened, and they'll go and actually confirm that the LAR paperwork is there in the record, and that's fine. You can get consent from somebody, have an LAR who may not be an LAR sign, go confirm, and then maybe it turns out that the paperwork that they provided isn't exactly what they thought it was. You can try to get the correct paperwork, or you can just indicate that this was a minor protocol deviation, no study procedures were actually initiated, and report that at your continuing reviews. Because you are going to see paperwork from an LAR that they think proves the LAR status, but it's the same way I provide paperwork to my apartment complex to prove something, and they say, no, this isn't what we need, this is exactly what we need. Patients don't always understand exactly what a hospital may need for that paperwork.
And normally it's done, we assess that paperwork beforehand. They send it in, we send them copies, they send it back, and we're sure we got the right stuff.
Perfect. So they tend to do it beforehand. I got that wrong. I apologize. So she also explored the patient's cognitive abilities. She asked her questions. And I know people kind of laughed when Jadai said that she's having a good day today, but for anybody who's known an Alzheimer's, a dementia patient, they do have really good days and they have really bad days. It can also really affect patients who are getting cancer drugs. My great aunt had really fantastic days. She was a charge nurse at a big hospital in Flint, Michigan, and there were days she understood exactly what was happening. And then there were days where she had no idea who anybody was. And that's pretty normal when you're talking about patients who are maybe at end of life or who have Alzheimer's, who have dementia. Their ability to understand what you're telling them may vary. And so if you do work on studies where you're going to be dealing with this vulnerable population, it's okay to ask potentially the partner, the caretaker, whoever it is, how are they doing today? Should I try talking to them? Are they having a really bad day, or are they having a really good day? Should I get assent from them? Because they are probably going to have a little bit more knowledge than you will. And that's fine to rely on them. And she also made sure that the patient gave assent. So the LAR still consented, and it's definitely possible that you could have an LAR consent even though she was able to potentially give consent. She may have only been diminished and not necessarily impaired or capacitated, but it's important for Jadai, who's the LAR, to understand what it is that he's consenting to on behalf of the patient. And the patient specifically said, yes, I want to participate, and then the LAR made the decision after that. So, regulatory considerations for informed consent. When is assent appropriate? So like I said, the federal regulations require that assent be obtained for children enrolled in research studies. They left it vague in terms of an age range. However, the UT Southwestern IRB and our affiliates, we've agreed that 10 to 17 is the age range that we want written assent to be obtained. When can assent be waived? And so this is this is a question that we do get quite a bit. It's a question that you should consider if you're dealing with children or with adults who have diminished decision-making capacity, because it may be appropriate to waive assent in particular cases. If we're talking about children who don't have the ability to give assent, it's fine for us to waive it because we don't want a requirement to be there when it can't be obtained. And so I know, there's quite a few patients who go to Children's who are on the autism spectrum. Some of those patients may be able to give assent. Some of those patients may not be able to give assent. And so you need to describe that in your protocol and your application about who these patients are, whether or not they could give assent, and then the IRB will consider the information that you gave us and waive assent if it's appropriate. And the same thing for adults. This is a question we always get. When must both parents sign the consent documents? So, this is going to come up later. Both parents must sign the consent documents if a study is more than minimal risk with no prospect of direct benefit. That is something that the IRB determines. So for anybody who's filled out EIRB, you know that when you get to section 10 or whatever it is, it asks you to determine the risk level. And then there's another section where you do the risk level again, but the risk level in the children's portion is specific for us to make a regulatory determination. If we decide that we agree with the determination that you've made or disagree with it, we will tell you after it's gone to an IRB meeting whether it is more than minimal risk, more than minimal risk with benefit, minimal risk with no direct benefit. And based on that, if it's a study where it's more than minimal risk and there's no prospect of direct benefit, the federal regulations do require that there be 2 parental signatures. Now, I know all of you are thinking, what if mom and dad are divorced and dad lives in New York and mom and child live here in DFW? It's still possible to get dad's consent, potentially, if he's reasonably available. So that's what the federal regulations say. They left it really nice and vague there for us to interpret on a case-by-case basis what reasonably available means. So I've seen situations where reasonably available did not mean that dad was in the Army and in Afghanistan, because dad actually had the ability to do a phone call with the coordinator and was really interested in saying yes or no to the particular research study. I've also seen cases where dad was on the front lines in Afghanistan and was not reasonably available. So it's going to be potentially a case-by-case basis sometimes if 2 parental parent signatures are required, but it's something that the IRB determines when we review and approve your study. And if you submit a consent form to us for children and we determine that 2 parental signatures are required, we will add that second signature block for you to the consent form before we stamp it. When is reconsent necessary? So that's something that comes up a lot with children and with adults who have diminished decision-making capacity. If we're talking about children, if they turn 18 while they're on the study, they have to give consent because they are now of legal age and can give consent for their participation. If we're talking about adults who have diminished decision-making capacity and you did not get consent from them, even though they potentially could have, you just got assent, then you need to get consent if their level of decision-making capacity rises to the point where they feel that they should make a decision now. If we're talking about impaired or incapacitated, where they did not have the ability to give consent, then you should get consent if they get to a level of diminished decision-making capacity and they do feel that they have the capacity to consent now. So if we're talking about Alzheimer's patients, it's not necessarily a part where you have to say, Amy just gave assent, and then the next day she's feeling even better, and now she has to give consent. That's not necessarily what we're talking about. We're talking about patients who had a traumatic brain injury, were not able actually to communicate with the coordinator whatsoever, had no involvement in the consent process, and then they become awake. Turns out that the brain swelling didn't have that much effect on their cognitive abilities, and now they can give consent. That's a patient who should give consent when they wake up. Who's authorized to make the determination of cognitive impairment? So this is something where it's probably the only point in the presentation where I say this may be determined by hospital policy, but according to the federal regulations and the Human Research Protection Program Policy and Procedure Manual, the caregiver or a psychiatrist, psychologist could make that determination. We do not require that be something in the medical record. We could have a patient come in, something just happened, and the person who's in charge of that patient, the physician, makes the determination at the bedside after an appropriate assessment. And how will the study continually assess cognitive state? So this is something that if you're dealing with this specific population with adults, not necessarily with children, but potentially with children as well, what is the plan here? And so you'll see when we come out with the EIRB updates, we're going to have a better way to ask the question about what's the plan? How are you going to continually assess these patients? Because you should be doing that. And again, when I say should, it's the federal regulations must. So reminders, the same reminders that we've been doing all along. Only study personnel may obtain consent, do it in their natural language, use a currently IRB-approved informed consent document. The date of the participant and the LAR and the person obtaining consent should always match. Leave no lines blank. Give a copy of the consent and HIPAA to both the study participant and the medical record. And make sure that you leave a really nice consent note in EPIC or on a progress note. So now we're going to get to the quiz portion that I would have done through Menti, but again, I was told not to use it. So we're going to wait for approval on that. So everybody be brave. We're going to do 6 questions, so you have to be brave for 15 minutes. Did anybody do that for me? Okay. So per the HRPPO policy, and I have the reference there, and I know everybody's memorized our policy, so you know exactly what I'm talking about. Who may assess a participant's decision-making capacity? A, B, C, D. So we'll start with A. B. C. Yeah. Yeah. A. B. C. And D. So Jan cheated the system because she just kept her hand raised, A through C. The correct answer is C.
No, it says who may, so participants, practitioner may.
Right.
Psychiatrist may, or both.
Right. But if you're doing a multiple choice question, you'd put C. She's cheating the system. 2 parent signatures are required if a study is A, minimal risk, B, more than minimal risk with prospect of benefit, C, more than minimal risk without prospect of direct benefit, and D, never. Great job, everybody. I intentionally gave some of the answers during the presentation. A 9-year-old patient turns 10 and 18 while active on a study. What is required? A, written assent at age 10. B, written consent at age 18. C, both. D, neither. Wait. Why aren't you clicking? There we go. That's weird. Yeah, this is a surprising one. So written assent at age 10 is not required per our policy and procedure manual. You can do it, but it is not required. It is also not required per the federal regulations. You do not have to get written assent if a child goes from not requiring assent per the institutional policy to now requiring institutional assent per the policy. However, if they turn 18 and they are active on the study, and that's, I know that can be maybe a nebulous statement, active on the study, but we'll assume that they're still coming to the hospital and having, a blood draw and an infusion, something like that, that you must get consent when they turn 18. Now, if we're talking about a patient who's maybe when they're 13, they gave their parents consented to samples being put in a database, and that registry is being kept open forever, that is not necessarily active on a study, even though that study is going to remain open so that you can keep using that data in the registry. A court-assigned LAR may always consent on behalf of the subject. True or false? So A, true. B, false. There were not that many brave people there. So they have the ability to do it, but it's not necessarily that you're always going to get consent from the LAR, because technically my wife could go and get assigned LAR status for me. And so that was a tricky question, but it's important that everybody understand that somebody may have an LAR, but that doesn't necessarily give away my rights to consent for myself. Does that make sense to everybody? So I wrote it so that it was really tricky. And this morning I reread it this morning. I was thinking, what the heck was I thinking 3 weeks ago when I had to go back through and look at my notes. So a participant with a diagnosis of Alzheimer's may consent for themselves. A, true. B, false. So again, not that many brave people. It's all right. True, because I didn't give you any information about how progressed their diagnosis of Alzheimer's might be. If we're talking about my grandmother, she has not been diagnosed with Alzheimer's or dementia, but I would also question whether or not she understands everything I always tell her. And I'm not saying that in a facetious way. She's just, sometimes forgets things, and she forgets pretty important things, and that's fine. And it's the same thing with a patient who's been diagnosed with Alzheimer's. They may be very, very, very early stage Alzheimer's. My wife's great aunt was diagnosed with Alzheimer's about 10 years ago. When she first got diagnosed, she was, going to sound like my grandmother, sharp as a tack. But now she does not have the ability to consent for herself, and she really has no ability to do much for herself. So at this point, she cannot consent for herself. But when she was initially diagnosed, she did. And then the last one, in Texas, a blank minor may consent for him or herself. So emancipated, A. B, educated. C, liberated. And D, enlightened. Now, if I were going to ask the children of everybody in the room, I'm sure they would disagree because they all think that they're very educated, liberated, enlightened. But it is emancipated. So that's, if you ever have a question about an emancipated minor or a minor who is pregnant, a minor who's part of the military, there's a lot of different criteria that may apply. First of all, check out the HRPP policy. Second, call the office and ask us, because specific guidance may be necessary in that particular instance. But it is possible potentially for somebody who is not 18 to consent for him or herself. And I think that our policy procedure manual does a pretty good job of laying that out, but I understand it's IRB talk, and not everybody understands IRB talk. So that was it. Any questions that people may have? And I will repeat the questions, so just get it to me, and then I'll repeat it for everybody. Yes?
I guess the circumstance that if you ever want to withdraw from a study, you can, but I think a child or a person who does not have the capacity to make that decision, if they say during the study, I want to do this, I don't want to do this, is everyone obligated to stop?
So the question was, we've talked about withdrawal, and I think we talked about that in February, that if a person wants to withdraw from a study, they can withdraw at any point, right? But what if we're talking about children and or an adult who has diminished decision-making capacity? If we're talking about children, that's easy, because assent is not like, or is just like consent, where it's an ongoing, the patient gets to continue to always have the ability to make a decision. If an adult always has the ability to say, I want to stop, a child also has that ability to say, this is too much, I'm done. In the case where we had the 46 blood draws, they could get into it, and maybe the nurse really is not that fantastic at getting the blood, or maybe the patient has really hard veins. I'm not assigning blame here. I'm just saying that the patient may say, I'm tired of getting stuck. And you know what? Like, I know, Mom, this is expensive, but I'm going to go get a job and I'm going to pay for my acne medication. That's fine, and the patient can withdraw. Jan could have withdrawn from that study as the child. Now, if we're talking about adults who have diminished decision-making capacity, that's where you may have to defer sometimes to the study partner. But technically, if the patient understands enough to understand what's happening to them and they say, no, I don't want to do this, then it really should be honored as much as possible. Now, if it's just, Jan had a patient one time who had a stroke, and the only thing that he could say was no. So you can imagine the logistical nightmare that would present for him of going up to anybody, and the only thing he can say to anybody is no. And I'm so glad Jan said this to me, because I'm going to steal this story every time I talk about adults who have diminished decision-making capacity. But if he goes to the grocery store and he smokes and somebody says, do you want a pack of cigarettes? No. Well, he didn't get what he wanted there. If we're talking about he comes to the hospital and this happened, he was supposed to show up for an MRI. It was a very early morning MRI. Jan was unable to be there due to a personal issue. The patient shows up and the people are saying, are you supposed to have an MRI? No. Are you part of a research study? No. The only thing he can say to anybody is no. So sometimes, take the no with a grain of salt maybe and talk to the LAR, find out, is this, I can only imagine when my daughter turns 2, she's going to say no all the time because she's so happy right now. She's at some point going to be kind of horrible, right? That's what everybody tells me. It comes back to bite you. If we're talking about adults who have diminished decision-making capacity, sometimes they do act like a child might, and so they might just say no to everything because that's what they're thinking in their minds at that particular time. So if you have that circumstance, feel free to call the IRB office, the HRPP office, and talk with us, and we'll walk you through the process. Other questions? I know it was so much easier to just submit them and then not be identified, so I'm really hoping that we get that back. Yes?
So we don't need consent once the child turns 10, which was originally enrolled in 9. But if the child decides to stop participating in the study, is it the child because he didn't originally sign the consent form?
So the question was, we have a child who is 9 or younger and did not sign Assent. Doesn't matter necessarily that they turn 10 or not. Really, the point is, can the child say, no, I don't want to participate at the beginning, or no, I don't want to participate at any time during study participation? And the answer is yes, the child can say no. We require written assent, but a child who is 9 may have capacity to give assent. And this is something where if we're talking about a child who's 2 and all they say is no to everything, do you want a cucumber? No. Do you want a cupcake? No. Do you want a lollipop? No. Then take the no with a grain of salt. But if we're talking about a child who's 9 and has the ability to understand what you're talking about and says, no, I don't want to participate, no, I don't want to come back to the hospital, no, I don't want to do something, then it's dissent. Other questions? You could whisper it to your neighbor, and then it's de-identified because your neighbor is asking the question. Okay. Well, thank you so much, everybody. Everybody come back in May because we're going to recap everything, and we're going to have some fun questions on the screen. Thank you.